I'd like to thank the BHIVA organisers for the opportunity to present this small community-based study. I'm in control of the slides. Sorry about that. This is really about informed consent, which is an ethical concept that's a cornerstone of ongoing medical research. Patient information is an important part of that, and its main aim is to ensure that people who are interested in going into a study or who engage in a study and become part of a study understand the main aims of the study, the risks and the potential benefits that are involved, and that participation is voluntary. And that iBase as a community project speak to many people over the year about their individual decision to join a study, but we also work collaboratively with a growing number of research groups. So readability scores is recognised by the NHS as an important tool for giving you a rough idea of how difficult or easy a piece of text is to understand. There's a 200-page NHS document for guidance for researchers, and perhaps more importantly, it gives you an idea of the percentage of the general population who could easily understand the document you're presenting them with. And perhaps even more importantly, the percentage of people who would be alienated from that document and not be able to easily understand it. The easiest way to understand how to improve readability is to use short sentences, really no more than 10 or 12 words, to use short words with 1 or 2 syllables rather than 3 or 4, and some of the calculators for readability look at basic grammar where passive sentences score poorer readability than active sentences. So our methods were to look at the body text of 9 ongoing research studies that varied from phase 1 to phase 4. Some were independent investigators, some were industry studies. The methods were to copy and paste text from PDF source files, lightly edit them in MS Word to improve readability. So we added punctuation so that headings and bullet lists scored as short sentences. The primary outcome was reading ease. Scores were calculated using a free online calculator, and we used 2 community-produced patient information leaflets as comparisons. So the choice of the scores we used is something called the Flesch Reading Ease score and the Flesch-Kincaid grade score, both of which are incorporated as options in Microsoft Word. Flesch Reading Ease has been around for about 65 years and is an integral part of plain English campaigns. The standard range for a score is usually quoted as 0 to 100, but you can go either side of those boundaries. But the target for for easy readability should be above 70. Flesch-Kincaid is a modified version of the reading ease score that converts it into a reading age. And we also used the SMOG grade score, which has been around since the 60s, which may be better indication for health information. It's used for oncology leaflets in the States. These are the equations. They're not as daunting as they look. You're really looking at the average word length and the average syllable length in the equations. These were from Wikipedia, and actually we had to correct the Flesch Reading Ease score. Wikipedia was wrong. Luckily, it's all now generated automatically. So the targets you're reading for, in the NHS document for producing patient information, they assess this as a reading score of above 80. But they don't actually explain which methodology they use to grade reading ease. And so it's the far column that I think is more important in seeing the percentage of people who could easily understand either tabloids or broadsheets or standard magazines. And then the block beneath that is from it's quite a good result, quite a good report on estimated literacy in the UK, and only maybe about just over half, 50% of the population have a higher than grade C, GCS grade C understanding of literacy, and that means half the population don't. So this is an example of the online calculator we used. You can cut and paste unlimited text into this box, so you can include 20 pages. It'll give you virtually an instant result, and And then you get the text statistics come out, so you can see that this example was one sentence with 120 words, and then you get the reading ease calculated. So it's very automated. It's not a value-based system. It's an easy thing to automate, and the version here, readability, the readabletest.com, gives you quite a nice interpretation afterwards. Charles Dickens didn't do very well. He went in, you can see this was -34 for this first line of A Tale of Two Cities. So the document statistics that we looked at, the first thing I suppose I'd highlight is that some of these informed consent sheets are over 20 pages long. And there's a sub-study of the START group actually that looked at reduced page count in terms of the, it's just as effective to understand what's involved in a study with a small informed consent sheet. But 23 pages is a challenge in itself if you're not so confident in literacy. The community examples are here to show that there's similar level of complexity, they're similar length documents. And you can see that the community documents are already using much lower word count per sentence. So these are the results. Unfortunately, all the scores we looked at, if you look at the mean range of scores, even the most readable current ongoing study has only had a score of 63, which is well below the target recommended by the NHS. And the community examples were doing better, really. And on the reading grade, a reading grade of 10 is a reading age of about 18, 17, 18, something like that. It's getting close to A-level standard, early graduate level. And a reading age of 6 it means you need 6 years of schooling, so it's a reading age of about 12. Limitations, we obviously only had a small number of studies, a small number of protocols. We didn't assess other aspects of readability in terms of layout and content, but the layout was pretty text heavy, so we probably underestimated true readability scores. We recognise that patient information is only part of consent and that the discussions with researchers and with health advisors is really important. But I think that if it's not able to be done for written information, maybe that questions the comprehensiveness of the discussions. But also, if it's readable, these documents, it's much easier to independently decide whether you want to join a study. Advantages of readability, I would propose that these are all fairly straightforward. You increase the pool of participants who are likely to engage in research. You reduce maybe loss to follow-up and maybe enable real informed consent. So the conclusions, I think we found that currently readability is pitched too high for most people to actively engage in research, and that given the care that goes into HIV studies, this seems a shame for patient information to remain an afterthought. I would highlight that this is not a recent concern. There's a huge body of literature that has pointed out for decades that informed consent is too high. It's not a UK-specific problem. It's not an HIV-specific problem. It's not even a research-based problem because there are numerous community-produced documents that have far too high readability, in my opinion. One easy way maybe to get a better readability was for ethical review panel to require that these statistics are included when documents are submitted. All these documents passed ethical review. So in Microsoft Word, you have to click a few options in order to get your statistics out like that. So these tools are easy to use. This is something you can learn to do. You can learn to write more readable English. And so I'd like to thank the colleagues who helped with the research. And there's a few links there to further information. And I'm happy to take questions.
Thanks. We have time for perhaps one question.
Oh, Duncan over here. Duncan. Hi. Thank you very much, Simon. That was really lovely. Quite often we write patient information sheets that we think are quite simple, although we haven't been doing the readability test. It goes to an ethics meeting and it comes back 10 times more complex. Are you planning on sharing these results with the National Research Ethics Committees? Because I think it could have a lot of input there.
Yeah, I think it would make sense to actually connect with the ethics boards themselves and to flag that this is, that over the years, informed consent has become increasingly complex, and there's already plenty of discussions where informed consent really is seen as an insurance policy, maybe for researchers and for industry, rather than a true informed process. So yes, we're definitely looking to this, yeah.